In this video, I'm going to talk about how policymakers can handle adverse selection. In particular, how do you get around the adverse selection problem in health insurance policy? This is super relevant to policymakers who are designing healthcare systems. As a matter of fact, my state, Minnesota, had a committee that was designed to think about adverse selection on MNsure, which is our Affordable Care Act exchanges in our state. And policymakers at the federal level, at the state level, sometimes even at the local level, have to consider adverse selection. So there are basically three different tools that policymakers can use to address the problem of adverse selection, and that's what I'm talking about in this video. So the first thing is, what is adverse selection? And I have other videos that explain this in different ways, with different degrees of technicality. So I'm not going to fully explain the problem here, but brief overview. Adverse selection arises from the fact that there's a maldistribution of healthcare expenditures across the population. As a matter of fact, the sickest 5% of the population spends half of all medical dollars, while the healthiest 50% of the population only spends about 3% of medical dollars. So when you have markets where people are choosing which health insurance they're going to buy or that they're going to select into, you get the problem that sick people want really high quality health insurance and healthy people don't want to subsidize those sick people. So what happens is that the high quality health insurance plans attract all the sick people, and that increases the cost of caring for that group of people because of who has selected in, which increases the price. That scares away the healthy people who don't want to cross-subsidize, so the healthy people are going to select plans with high copays, high deductibles, lots of red tape, and since they don't use the care that often, they don't care that much about the quality of the care or the red tape or the copays. They just want a cheap plan. So the healthy people will all clump together in these low quality plans, and the sick people are left pooled together with really high cost insurance. It's a huge problem when we're talking about health insurance, and so what can policymakers do to deal with it? So there's three solutions. Basically, these are eliminate competition, adjust for risk, and risk pooling can be a solution, although hasn't played out in practice. Now, these solutions all have problems, so I'm going to talk about why does it help with the adverse selection problem and what problems are we still left with if we use this particular tool. So tool number one is eliminating competition. If you don't give people any choice about their insurance, the healthy people can't evade the sick people by choosing different plans than the sick people do. So everybody's clumped together. The healthy people are forced to cross-subsidize the sick, which completely eliminates this problem. Now, before I talk about the disadvantages of this, I want to point out the places where competition has been eliminated. So the most obvious is single-payer healthcare systems or socialized medicine, where there is no choice about who insures you, so everyone's clumped together. Canada's system, the UK's system are the most classic versions of this, but those systems don't have the adverse selection problem. The other place where we see this that people don't always think about is employer-sponsored health insurance. If you get your health insurance through your employer, what that means is generally you don't have a choice about the company that's insuring you. Now, oftentimes there's different levels within the same company, so you might be given different tiers you can choose from, but if the same company is offering all three tiers, the company can cross-subsidize the healthy and the sick, even if they select into the different tiers. If it's all Blue Cross Blue Shield tiers, you just select which one within Blue Cross. You don't have the adverse selection problem because it's easy to cross-subsidize. The key here is that you don't choose the company that insures you. Who does choose that? Well, it's the HR person in your company. Those people have a lot of power, and generally they do a pretty good job. They compare different health insurance options. They try to choose which one's going to be most attractive for our employees. So there is still accountability. Somebody's choosing that insurance, but that person isn't you. It's not each individual choosing their health insurance based on their health status and matching their health insurance needs to their health status. So for many, many people who get insurance through their employer, competition between companies is eliminated. And that's how employer-sponsored health insurance ends up eliminating the adverse selection problem. Now, I should also point out here, if you work for a large company, on average, employees who work there are likely healthier than the general population. Just because if someone's unhealthy, if they're really unhealthy, they probably can't work. So the fact that you can work and you can get insurance through your employer already puts you pooled with a group who's healthier on average. And of course, anytime you're pooled with a healthier group, the costs of insuring you go down. So that's the first solution, eliminate competition. Now, what's the problem with this solution? Well, there's a couple of problems. One is the fact that people can vote with their feet. That holds insurance companies accountable. They have to pay attention to what customers want. They have to watch costs to keep premiums low. They have to do a whole bunch of things where part of the accountability is the fact that you can buy a different insurance company if you want. Now, there's some issues with this, and if you want to learn more about those, I have a different video on that. I'll put a link below, but it's basically the race you to the bottom concept ends up having insurers compete to keep out the sickest patients. So that's an issue, but we'll put that one aside for now. But having different options that people choose from does lead to experimentation. It leads to an experimentation in the way the health insurance company is organized, the way insurers hold doctors accountable, the measures they use for pay for performance, the tools that they offer customers, online tools for comparing prices, for tracking your care, all the different things that health insurance companies do. Having different insurers that are sort of competing and watching what each other are doing, that incentivizes experimentation. And if you eliminate competition and put everybody under the same system, you lose some of that experimentation. So I'm just being honest about the costs and the trade-offs for each of these ways of addressing adverse selection. Now, what's the second way that policymakers can address the adverse selection problem? That is risk adjustment. So this would be in a situation where people still choose their own insurance, but the payment to the insurance company is adjusted for the person's risk. And I'm going to talk about two different examples of this. One is Germany's healthcare system, and the other is the Affordable Care Act exchanges. And these two have different ways of handling this, but they both involve risk adjustment. So in Germany, basically every person, if you buy into the system, which most people do except for really rich people who buy insurance on the private markets, but most people pay into the public system, in which case the government gives them basically a voucher. And I talk about it this way because it's easy to visualize if you're imagining someone holding a voucher, and this is essentially how it works. Whether or not you physically hold a voucher and give it to a company is another matter. But imagine someone getting a voucher from the government. They've paid in their 15% of their salary. It's how much you pay into it is adjusted by income. You get a voucher and you take that voucher to whichever insurance company you want. Now, these insurance companies have to be not-for-profit, but they're competing with each other for customers. So you get to choose which insurer you want to go with. Now, the key here is that the voucher is personalized to you. So if you're a sicker person, you're more expensive to insure. And the government will adjust your personal voucher based on how sick you are, based on all of your risk factors. So that when the insurance company accepts you by accepting your voucher, they know that on average, they're not going to lose money by taking people who are sicker. That's generally how risk adjustment works. Now, I'm going to tell you the disadvantages of this in a second, but first let me explain a slightly different way of handling risk adjustment. So the health insurance exchanges in the US, these are mandated by the Affordable Care Act, are where you would go to buy insurance if you don't get it through your employer or if you don't get it through Medicare or something. These are basically websites that are like Travelocity for health insurance, and the government regulates how these websites work. These are the health insurance exchanges. Now, the companies offering insurance on there are private insurance companies, and you choose between them. So the problem with adverse selection is that sicker people are going to choose the higher quality health insurance plans. So to address that, what government does is it will adjust for risk after you've chosen your insurance. So there's a certain time window every year when you can buy from the exchanges. So after the dust is settled on the exchanges, after everyone's picked their insurance for the year, the insurance companies show up around a table, and not really a table, but I like to make things visualizable, and they look at the pool of people who selected into each insurer. And of course, there's a government official in the room kind of looking at how things settled. And if they notice that a couple of the insurers attracted more high-risk people, more sick people, then the government official in the room is going to tell everybody else to give some money to the insurers who attracted more sick people. So let's say Blue Cross Blue Shield and Aetna happen to attract a higher share of sick people than the other insurers at the table. The government's going to say, okay, we see that actually by providing this high quality insurance that attracts the sick people who know the true experience of healthcare, Aetna and Blue Cross Blue Shield could lose money because they've just attracted too many sick people, and the other companies seem like they're doing well because they've attracted all these healthy people. Instead of letting those other companies roll in the dough and Blue Cross and Blue Shield and Aetna lose money that year, the government says everyone pay Blue Cross Blue Shield and Aetna X dollar amount. And of course they've come up with the payments based on all these statistics that they've calculated. And Aetna and Blue Cross Blue Shield get that extra money to cover the high cost patients. So it's an after the fact adjustment for risk, as opposed to Germany's system, which does a before the fact risk adjustment that goes onto the individual vouchers. So those are just two different ways of adjusting for risk with health insurance to address the adverse selection problem. Now, what are the problems associated with this particular mechanism? Well, one of the problems is the fact that it's actually really hard to perfectly adjust for risk. The only way the government can do that is through observable data, which is basically potentially your medical records, but the government may not even have your medical records. So it has to use characteristics like your age, your neighborhood, whatever data it can glean, that's what it has to use to adjust for risk. And so it's not just that the risk adjustment isn't perfect. Sometimes the system can still be gamed even when there's risk adjustment. As a matter of fact, sometimes the risk adjustment will actually make the adverse selection problem worse. Now, that is a bigger thing to explain than this video will allow, and I will put a link below to a video or two that explains it in more detail. But basically, even if you adjust for risk, it doesn't get rid of adverse selection, and that's basically because people know more about their risk and insurers know more about a person's risk than the statisticians who are risk adjusting for the government. Those statisticians have a very crude picture of every person's risk status, whereas the individuals who need the insurance have a very detailed picture of their health status and their situation. And the doctors certainly have more of a picture of each patient's health status. And even the insurers who have an incentive to cream skim the healthiest patients, they have information to work on that's better than the government statisticians. In particular, they can choose to advertise in gyms and to advertise at gala events where really healthy people are likely to be. And those strategies alone will allow them to cream skim, and therefore adverse selection is at play. So these first two ways of addressing adverse selection, that is eliminating competition or adjusting for risk, these are the most common and honestly the most effective ways of addressing adverse selection. There's a third one that I should throw in the mix, and that is risk pooling. Now, risk pooling is essentially having a pot of money that you can tap into for people who get locked out of the system due to adverse selection. So before the Affordable Care Act, we know that people with pre-existing conditions sometimes got rejected by all insurers. And in which case, states had a pool of money that funded insurance. It was basically state-provided insurance for people who could prove that they were locked out of the system. And you can have different formats of that. It's basically you have backup money to plug the holes in the system wherever they appear. Now, the problem with this one, of course, is that these patients are so expensive. If you're just having people with pre-existing conditions and people who got locked out of the system coming into your pool, those people are so expensive that you need a lot of money to cover their healthcare costs. So what ended up happening is sometimes that insurance wasn't very good, wasn't sufficient, and it's being applied to the people who need it the most. So I'm not super big on risk pooling, but I need to mention it since I'm mentioning the different tools that policymakers use to address adverse selection. And of course, if you have a big enough pot of money, this could work. It's just that the states who in the past have run these risk pooling programs haven't funded them well enough, and there's been issues with them. But those are basically the 3 different tools that policymakers have for addressing adverse selection. There's lots of different ways of actually implementing those tools in practice, but these are the 3 broad philosophies, broad approaches. So I hope you found this helpful in thinking about what are the solutions to adverse selection, what can policymakers do, what have they done, what are the costs and benefits of each of these, and I hope it's given you a little bit of hope that adverse selection can be addressed, even if not perfectly.